So, dear aspirants, when you're preparing for any set, especially plastic surgery, the main competition is yourself, because for the few years, what I've realized is securing 50% of the mark is becoming tough, and therefore, choose your negatives properly, and be very prudent in choosing your various options, because the negative is going to pull you down. The few questions which I'm going to put and the explanation is just um, to brush up the various important topics. I might not be able to cover the entire topic, but still it will be of some help, especially for the last week. Once again, I would like to tell, don't feel intimidated. Don't go for new portions when you're near the exam. You have to revise the old portions, especially Graben Smith is the book. Keep revising the same Graben Smith, because everything looks the same in plastic surgery. Everything is volatile in plastic surgery. Okay, with this, I'll start the class. For elbow animation, all can be used except Brachialis, LD, pick major, and triceps. For elbow animation means this is a question on the brachial plexus. Brachial plexus is a little bit of a tough topic, and the nerve injuries and brachial plexus are a little bit tough, and therefore I would put few questions on that. And also, it was asked in the previous SS INISS NEET. Okay, gracilis is used as a free flap. Latissimus dorsi and pectoralis major muscles. Both the muscles are starting from the trunk, and they can attach to the appendage, and therefore they can be used for elbow reanimation. Whereas trapezius is a muscle which starts in the scalp and is attached to the trunk, and it's not involved in the upper limb function at all. So sorry, friends. Today, because of an emergency case, I am not in my regular place where and the internet connectivity is quite bad. But I would try to manage somehow. So the surgical management of adult brachial plexus injury, it can be tendon transfers. That means when do you go for a tendon transfer is when the brachial plexus injury is unable to recover on its own, and you have also crossed the period wherein you can do a nerve repair, etc., which is around 18 months. So 12 to 18 months, most of the textbooks will give 12 to 18 months. So there is a golden time for the reinnervation or to operate. Hello? Yeah, no, because I'm standing in the balcony. That is why I'm okay. I cut my video. Yeah, okay. Because I'm from in an outdoor only. The net is coming. That is why. Yeah, okay. I'll try to open once. Yeah. The proximate that is why so tendon transfers are mainly used only in cases where we have missed the golden period, and the nerve recovery hereafter is not possible. Proximal exploration and visualization of the site of injury and concomitant nerve reconstruction is one method of reconstruction wherein we have not missed the period. Like we are within the 6 months to 9 months period and nearly up to 12 months period. And therefore, during that time, even if you go inside the neck, you identify the nerve injury and operate and put a nerve graft, it is possible. Then is the procedure called as the distal nerve transfers. Here, again, you have crossed the time uh, to that level that now you cannot go and do operation in the brachial plexus nerves and connect them, but you can use other nerves which are expendable nerves and connect them to the important muscles of the shoulder appendage and hand. So the factors which affect among the strategies, like I told, is the time since trauma. Okay, also institute-wise, whether the surgeon is able to do microvascular surgeries, the extent of the zone of injury, whether it is spinal cord avulsion in which nothing can be done. In spinal cord avulsion, there is no option of exploring, operating, putting nerve grafts, etc. It is always a nerve transfer or a tendon transfer, and available of the various donor nerves or the musculotendinous units. Okay, the same trauma could have also tarnished your available donor sites or the other muscles. So these are the important topics. So in proximal exploration, what we will do is it is both a therapeutic and a diagnostic procedure. After opening, it confirms what sort of injury is there. After which the nerves will be identified, and we use a cable nerve grafting using the various nerve grafts. If there is a root avulsion or spinal nerve ruptures with a good proximal stump, without a good proximal stump, once again, stump to coaptation, then only we go for nerve transfers. So basically, there is no inherent nerve stump to co-opt into the cut end of the nerve. Okay. So when nerve transfers can be done as an intraplexal or an extraplexal transfer. Intraplexal means within the brachial plexus itself. Extraplexal means from other sources, not within the plexus, but other nerves. So commonly used intraplexal nerve transfer is like from the cut end of from the spinal nerves, from the cut intact roots, etc. Extraplexal donors are usually contralateral C7, intercostal nerves, phrenic nerve, or even the cervical motor branch nerve C3 and C4. Proximal exploration should be done within 3 to 5 months. Here I have told like the gold standard for muscle regeneration is 12 to 18 months, because that is the time in which the motor end plate potentials atrophy by the time. After which, even if there is a recovery, the muscle is not going to function. So that is why any form of nerve repair or nerve transfer should be done within, so that the nerve regeneration is within that period. That is why the proximal exploration should be done by 3 to 5 months of time. Okay, whereas the distal nerve transfer should be done within 3 to 9 months post-trauma time frame. Here, the advantage is the operative site is away from the injury. and it can avoid operating the fibrous tissues. The disadvantage of the distal motor nerve transfer is it weakens the intact functional portions of muscles, and cortical adaptation with the post-motor re-education is also required. Cortical adaptation means, suppose if you are taking the nerve from the flexor digitorum superficialis and giving it to the extensor digitorum, the cortex should now reorient that the muscle which was doing a flexion is doing an extension now. Sensory nerve transfers can also be done to restore the sensation. We all speak about motor recovery, but sensory recovery is as important as motor recovery. This is a big, huge tabular column in which the various motor nerve transfer options are given. You can see for radial nerve, the FDS or the FCR or the palmaris longus fascicles of the median nerve can be used. Okay, or the pronatory teres branch of the median can be used, or the FCR branch of the median can be used. And this is there in your Graben Smith. So this is a very important table. One of the question is going to come from this table only. Here you can see for musculocutaneous nerve, usually uh, for a musculocutaneous nerve, we usually use either the median nerve or the ulnar nerve. Ulnar nerve transfers are called as the Oberlin transfers, and therefore the question is the ulnar nerve, the branch is taken and put to the brachialis and the biceps, which causes the elbow flexion. Also, the axillary and the suprascapular nerve are usually neurotized by triceps branch of the radial nerve. So, among various peripheral nerve transfers, Oberlin's transfer, which is nothing but the median and the ulnar nerve branches to the musculocutaneous branch, and triceps branch of the radial nerve to the axillary nerve, are very important transfers. The sensory transfers, like given in this table, a lot of sensory transfers can be given. In brachial plexus, basically the concept, whichever sensory nerve is intact and workable, you give it to the sensory nerve which is not working. So this is an important table which if you read, you can attend the sensory nerve transfer options. Tendon transfers. The initially option is the nerve transfers. Now is the biochemical restoration of the tendon transfers. This is for late presentation, more than 9 months. The tendon transfer or the free functional muscle transplantation is usually a life board. It is not the first procedure. Conventional tendon transfers are done only for incomplete brachial plexus injuries. Tendon transfers are usually paired with tenodesis or arthrodesis of the other joint so that the function is finally wholesome. The most common free functional muscle transfer is the gracilis myocutaneous muscle transfer, which is done for the upper extremity flexion. So again, the various tendon transfers and the free functional muscle transfer options are given here. For the shoulder, upper trapezius transfer can be given, or a lower trapezius transfer can be given. This is not for elbow. For elbow, usually biceps to biceps, brachialis to triceps, triceps to biceps can be used. Even the latissimus dorsi and the pectoralis major muscle can be used, or stainless flexoplasty can be used, in which the origin of the medial epicondyle flexors is released from its medial epicondyle, and therefore its length is increased. That is called as the stainless flexorplasty. And finally is the gracilis free functional muscle transfer. The various complications are in a neck exploration. You can have a lymphatic leak, carotid or interjugular vein damage, or a pneumothorax. These are very important complications. And in distal nerve transfers, especially while harvesting the intercostal nerves, you can damage the pleura and cause pneumothorax. And for other tendon transfers, there can be local failures due to bowstringing of the tendon, and choosing a wrong soft tissue interface to transfer the tendon, etc. And in FFMT, free functional muscle transfer, always a microvascular complication leading to partial or the total flap loss is a very important complication. Median nerve injury. What are the signs which are useful in the median nerve injury? We all know that Frohman sign, pin test, and the card test are all ulnar nerve injury signs. Only ape thumb deformity is a median nerve injury sign. Of the tendon transfers, by EAP was shown for achieving with thumb function. This particular question, the picture was given. EAP was taken and attached to the abductor pollicis brevis, and they were asking for which. So it is basically for opposition. So in median nerve injuries, how to go about will be seen in next few slides. Median nerve is a nerve which has supply from C5 to T1. Okay. And as you can see in the nerve tree, it supplies almost all the okay, elbow joint, pronator, flexor carpi radialis, palmaris longus, flexor distal superficialis, flexor pollicis longus, flexor distal profundus, and pronator quadratus. Almost entire forearm is supplied except for the ulnar 2 FDPs and the flexor carpi ulnaris. It also supplies the palmar cutaneous branch, which supplies mainly the palmar triangle. Then it supplies the thenar muscles, abductor pollicis brevis, flexor pollicis brevis, opponens pollicis, first two lumbricals, and radial 3.5 digit sensory skin. Okay. Anterior interosseous nerve is a nerve which is 6 to 8 centimeters distal to medial epicondyle. Okay. Anterior interosseous nerve is a pure motor nerve which innervates the flexor pollicis longus and flexor digitorum profundus. Median nerve continues distally. Like I said, it gives the palmar cutaneous nerve and the radial 3.5 fingers. The recurrent motor branch mainly supplies the thenar musculature, abductor pollicis brevis, flexor pollicis brevis, and opponens pollicis. The motor innervation of the index and the long finger lumbricals is from the common distal nerves of the median nerve. The ulnar two lumbricals are supplied by the ulnar. Functional deficit following the median nerve. In case of high median nerve palsy, there will be loss of even the pronator function, index and long finger function loss, thumb IP joint flexion loss, and thumb opposition loss will be there. So the functions to be restored in a case of high median nerve palsy is, of course, from the bottom thumb opposition, thumb IP joint flexion, index and long finger DIP and PIP joint flexion. Okay, so here you can see in the proximal median nerve lesions, okay, there is a Pope's blessing sign or the Benedict sign. In distal median nerve lesions, there is a median claw when the patient tries to extend the finger, and this is the area of the sensory deficit. So the various, initially when there is a median nerve palsy due to various reasons, we have to, of course, treat the pathology. If treating the pathology is not an option, or even after treating the pathology, there is a median nerve palsy, you go for the tendon transfers. Abductor pollicis brevis is the most important muscle in the thumb, and most of the tendon transfers are to recreate the abductor pollicis brevis function only. Okay. Among the vectors, the best, whenever you consider a tendon transfer, three main things have to be remembered, which is the donor, which is the insertion site, and what is the best vector. Okay. So here the donor, of course, the recipient site, of course, we know is the abductor pollicis brevis in insertion, which is at the radial aspect of the proximal phalanx of the thumb. The best vector for the opposition transfer should be parallel to the ABP tendon. It should be from the pisiform to the base of the proximal phalanx of the thumb, because in addition to opposition, it can cause, because it will give the best opposition, pronation, flexion of the MCP, and palmar abduction. Pulleys used to correct the vector are loops of FCU, palmar aponeurosis, transverse carpal ligament, and the FCU tendon itself. Four commonly used opponensplasty procedures are palmaris longus opponensplasty, also called as the Kametz procedure; flexor digitorum superficialis ring opponensplasty, also called as the Bunnell or the Royal Thompson's; EAP transfer is also called as the Burkhalter or the Zancoli; and the AB abductor digiti minimi or the Huber's transfer. So Kametz transfer is mainly indicated in carpal tunnel syndrome, especially with an advanced thenar atrophy. The advantage of this particular transfer is, in addition to releasing the carpal tunnel, you can do the tendon transfer within the hand itself. Ease of harvest, same surgical field. There is no lack of any functional deficit. Because there is no lack of any functional deficit, because palmaris longus is a expandable muscle only. The disadvantages are the tendon is damaged in traumatic median nerve. It is a very weak muscle, and the vector of pull is not ideal for producing a true opposition. Huber's transfer, it's abductor digiti minimi transfer. This cannot be done in ulnar nerve palsy because abductor digiti minimi is supplied by the ulnar nerve. It is tunneled subcutaneously to the tubercle of the ABP tendon. The transfer is synergistic to opposition and provides a good strength and excursion. But the problem is there is a limited ability to produce a palmar abduction, because the abductor digiti minimi itself is a very small muscle. It is usually indicated in children with hypoplastic thumb deformity. EAP opponensplasty, this is what was given in our option. It is used in high and low median nerve palsy. Why high median nerve palsy? Because when there is a high median nerve palsy, you can use the sensors, because most of the flexors are gone, and taking any muscles from the ulnar is going to weaken your whole hand. Here the EAP is routed around the wrist for the best vector, and that produces a good opposition of the thumb. Advantages are ease of harvest and available in high and low nerve palsies and minimal functional deficit. Here you can see the EAP, which is usually harvested by two stepladder incisions of the index finger at the MCP joint. EAP is usually found as a ulnar aspect of the MCP joint because the EAP has two tendons, extensor tendus proprius and the EDC leaf to the index. Then it is wrapped, and here you can see it is attached to the base of the abductor pollicis brevis. Patient with history of pain while working, increases on flexion. There is a numbness, tingling in the thumb and the index finger. Whenever thumb index finger is coming, it is a median nerve compression. Okay. So if there is sensory loss in the palm, it is a pronator teres compression and a proximal compression. If there is sensory loss is not there and the sensation in the palmar aspect is there, then it is a carpal tunnel syndrome. This is a very important point. Diagnosis of CTS is mainly by history and physical examination. Okay, aching in the carpal tunnel area, numbness and tingling of the radial aspects of the death, especially at the night. They wake up early in the morning, they shake their hand to relieve them of pain. Atrophy is a very late sign. You have to understand the nerve is a very sensitive tissue, so paresthesia is common and the first sign in compartment syndrome. Similarly, whenever there is a carpal tunnel syndrome, also the paresthesias are first. Later on, only the motor findings will come. Okay, few provocative tests like Durkan's test, Fallon's test, Tinel sign, scratch test, they are all used. Electrodiagnostic test is a must. Non-operative treatment are early splints, decreased tendon excursion, decreasing the pressure, keeping the hand in a neutral position, etc. Giving anti-inflammatory medication, steroid injections, diuretics, and oral steroids are not indicated because they decrease the intravascular volume, but they might not decrease the interstitial edema. Vitamin B6 is also helpful if there is a peripheral neuropathy. Operative treatment is indicated if conservative methods and medical methods are not working out. The transverse carpal ligament and the distal antebrachial fascia of the forearm is released. It can both be done by a endoscopic method or by a open method. And in both these methods, after releasing an internal neurolysis is not always a must. But of course, if you find scarring ischemia, we can do it. In the proximal median nerve entrapment syndrome, the compression of the median nerve is at the elbow. It causes wrist and hand pain, but there is no spontaneous pain in the region of the pronator. It is only exacerbated on sustained forearm pronations. Again, here all the symptoms of median nerve will be there, but the patient will be unable to pick up things, especially he will drop things when the wrist is being in flexion. Intermittent aching also will be there. Hand weakness involves the FPL and the FDP and the pronator quadris also. Numbness with proximal median nerve impairment is a late symptom and typically occurs at night. The diagnosis is with symptoms. Then the symptoms of the hand numbness related to the proximal median nerve entrapment is mainly provoked by firm palpation of the median nerve, just proximal and distal to the elbow crease with pronation against resistance. And the numbness occurring in less than 60 seconds is considered abnormal. To assess the strength of the muscles innervated by the AIN should be done, anti-interstitial it should be done, and the patient cannot do a O sign. FPL is tested with the wrist in the neutral and the thumb metacarpal abduction. In PME, the palmar cutaneous nerve, proximal median nerve entrapment, palmar cutaneous nerve branch tends to be involved, whereas in a carpal tunnel syndrome, it is not involved. Electrodiagnostic studies will rule out other causes of nerve dysfunction. EMG studies will also tell how are the muscles distal to the area of the compression, because it is a medical legal. You have to tell that when you release a carpal tunnel syndrome, the motor recovery will not be there. Only the further progression of the disease is decreased. The various non-operative treatments in the pronator nerve syndromes are doing ergonomic modifications in your day-to-day life. So, for example, if he is a musician, using a split keyboards, avoiding the pronation, using a vertical computer mice, voice-activated device, etc. If the medical and the non-surgical, if the medical treatments are not working out, then the operative treatment is the surgical decompression. All areas of possible compression are released, especially the Struthers ligament, which is a ligament which connects the spur to the medial epicondyle, the deep fascia of the pronator teres muscle, bicipital aponeurosis, deep fascia of the ulnar origin of the pronator teres, deep fascia of the humeral origin of the pronator teres, and fascia of the arch of the FDS. Digital arteries are formed by which vessel? The answer is digital arteries are from superficial palmar arch, which is formed by the ulnar and radial artery, but the main contribution is from the ulnar artery. The brachial artery divides into the radial and the ulnar arteries in the antecubital fossa and runs towards the radial wrist, radial to the FCR. Larger dorsal branch passes through the snuff box to the deep arch in the palm, and smaller volar branches contribute to the superficial arch. Ulnar artery runs between the FDS and the FDP muscle groups. Palpable, it is radial, palpable radial to the FCU, radial to the ulnar nerve in the Guyans canal. Large volar branch usually completes the superficial palmar arch, and the small dorsal arch completes the deep palmar arch. Whereas the radial artery, the larger branch contributes to the dorsal arch, and the smaller branch contributes to the volar arch.